Good morning, good afternoon, and welcome everyone to today's webinar, Patient Religiosity and Desire for Chaplain Services in an Outpatient Primary Care Clinic. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are all delighted you could join us today. Some housekeeping instructions off the top. This webinar is being recorded. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenters by typing your questions into the questions pane of that same dashboard. You may send in your questions at any time during the presentation. We will collect these and hope to include them during a Q&A session at the end of today's presentation. I would like to bring your attention to a couple of our Transforming Chaplaincy events and educational initiatives that we're running. We offer, if you have an interest in research literacy, we offer an online 5-week course that starts at the end of this month on May 31st, Research 101. We have a summer camp that we're holding this year in Los Angeles at Cedars-Sinai. There's a QR code there and a bit.ly link, so please check both out. They'll give you plenty of information on the program. It's a week long. It's very great time together. Very intensive week, and you will learn a lot. It'll be good to be together. Our partners at Northwestern Medicine are having 2 days of webinars next week on improving spiritual care and palliative care. And I think that's it. And with that, I'm going to turn things over to Petra. Petra Sprich is today's host and moderator. Petra is a former Transforming Chaplaincy Fellow who received her Master's of Public Health at the University of South Carolina. Petra was an oncology chaplain for 7 years, but is currently a doctoral student at the University of Alabama in Birmingham.
We are so glad that you are all here for today's presentation. And we are glad that our panelists are here to present because the work they're doing is so important. Today we have presenting Reverend Katherine Henderson. She is the Senior Clinical Chaplain for Outpatient Spiritual Care in the Duke University Health System. She is the first person who's worked in that role. In addition to her clinical responsibilities, she's a lead researcher on a few projects in narrative medicine and the outpatient chaplain's role in advanced care planning. Presenting alongside of Katherine, we have Reverend John Oliver. He's the Director of Chaplain Services and Education at Duke University Hospital. He's an ACPE educator and has a DMin focused on pastoral care to those who've experienced traumatic events. And presenting with them is Dr. Patrick Hemme. He's a primary care general internal medicine physician. He's an associate professor at Duke University and director of residency education at Duke University Outpatient Clinic. And we're glad that one of his many research interests is co-training chaplains and physicians. And we're glad that he's also part of this interdisciplinary team. And with that, I'm going to turn it over to you guys for your presentation. Thank you for being with us today.
All right, thank you both so much for the warm introductions and for this opportunity to share. I hope that we will be able to communicate during this time a bit of our work and also our passion for these projects and this outpatient setting and the interdisciplinary partnerships that bring it to life. So let us begin. All right. I am just going to confirm. Can you give me a thumbs up? Can everybody see that the slides are advancing? Can you guys see the next slide, the presentation outline? No. Okay. Hang on a second. This was my concern. Okay.
There you go. Yep.
Oh, you're seeing the presentation outline?
Mm-hmm.
Fantastic. All right, here we go, rolling forward. So this is our outline for today. We're going to share a little bit about how we have built and are building an outpatient chaplaincy practice. here in the Duke University system. We're going to talk about the research partnerships that have been bringing this to life and our initial publication, rolling right into our current publication, which is the primary subject for this presentation. And the title of that is here. And then we want to just seed a conversation, which we hope will be ongoing, about future research directions and practical considerations, and what we talk about as kind of the momentum and the value proposition, if you will, of having a outpatient chaplain in a system like this. We hope that we will be able to throw out ideas and partnerships and hear from you all, either at the end of this presentation, during the chat and questions, or afterward. If this sparks your interest and you might like to talk further, we would like to hear from you. So with that, this is how we orient ourselves to this practice. We began with the idea that perhaps there are some high need outpatient spaces that were not being served by spiritual care. We identified one particular clinic that we'll tell you more about in just a minute. We partnered with staff champions within this clinic, existing staff champions who were open to the idea of integrating a new discipline into an existing complex system of care that already had several disciplines working. We worked together to assess the existing staff system and to build strategic relationships. So really key points here for us were having an innovative practice and an interdisciplinary team that was used to trying new things and working together across professional boundaries, and also a team that had already an awareness and sensitivity to patients' spiritual needs, the different types of needs, and the particular needs that arise in our communities. It was also important, critically important, to have embedded social workers who wanted to be partners on this, as well as other medical and administrative leadership that was open and willing to work together. And finally, we have an unusual and very rich environment here with lots and lots of learners. So we have over 70 internal medicine residents that are learning how to be primary care physicians in this setting. We also have learners from nursing and from pharmacy and from social work. Starting in the fall, we will also have a chaplain intern working alongside me here. So this is a rich and complex system, but there were multiple points of entry and partnership that allowed this new practice to happen. And so we started really small. At first, I was the first intern here. I was then a chaplain resident here. We built the position slowly over time. We increased the clinical hours as the demand increased and as the comfort of the system increased to generate more referrals and more opportunities for partnership. And we'll speak more to this later, but as we consider this a pilot project that grew in phases, and that has now grown beyond this single clinical setting to looking at other high need outpatient settings as well.
All right, that's my cue. So this is a dated picture of the Duke Outpatient Clinic. It's recently gotten a little renovation, but it's an adult primary care practice in Durham. And we have the blessing of being able to care for uninsured and many publicly insured patients. So have a lot of people who are living in poverty and difficult backgrounds. And we suspected, but have learned more about, that we have a population that has high proportion of spiritual distress. And as Katherine already mentioned, we have a large number of doctors coming through in their training, plus people from some subspecialties like endocrinology or cardiology. Obviously, we have all of the other, we have nursing and pharmacy and social work and case management that does some wonderful work with patients. And so with each of these different disciplines, we have learners who are coming in because it's such a dynamic place with a lot of people interested in education. Pictures of our team. So as mentioned before, we created kind of a new partnership here, pictures of several of us. We realized early on that that grief was something that we as doctors, as social workers, had seen a lot of. It frequently comes up incidentally or obviously in the visits that we conduct with patients. And so we had this team of a chaplain leader within the health system, John, 2 social workers, and there's a picture of 3 of us physicians who worked on the initial phases of this project.
And I'd like to just say, we as the chaplains are grateful for our colleagues at the DOC who saw the need for someone to come support them around the grief challenges their patients were facing. And the way we developed it, as Katherine said, it was kind of an incremental process. We began with her out there as an intern, and then slowly became a 1-year paid grant funded position. And now we're up to a 3-year grant funded position, looking more and more towards further development of the position. But all of this comes from the deep and good work of team building. And so this is our team, and we've worked hard to manage that. And there are shout outs to both of these colleagues here on the team that have really helped make this process work. So that's a big part of our journey too.
All right, so as it has developed, this is my scope of services. I do a fair amount, quite a lot of individual patient care. A lot of that is by referral. And again, this really speaks to the importance of relationship building. So these referrals come from all of the staff, any of the staff in the building, from folks who present to the front desk for an appointment and are in obvious distress, all the way through to all of the learners we've been talking about and interdisciplinary team members. So I take the importance of referrals and relationship building very seriously, because that's where most of my contact with patients comes from. I also do interprofessional work. This is a real privilege and joy of the role, to be able to, certainly here at the Duke Outpatient Clinic, but also in my other clinical role, which we'll introduce later, actually getting a chance to see patients alongside several other disciplines and then come together in interdisciplinary team meetings where we present to each other our salient findings in preparation for making a joint plan for care. And again, these things have evolved. I'm finishing up my 4th year here now. So the care began with individual patient care exclusively, and it has evolved to also include a more systems level role in advanced care planning, which I'll also come back to later. So the linchpin of our grief support program here is called the DOC Grief and Spirituality Group, and that's really built on a model of trauma-informed spiritual care. And those group visits are conducted always with my social work colleagues. So that is a joint chaplaincy and social work group, and we're listening for different things, and we take turns leading the group, and then we always have a debrief afterward. I do a lot of staff care. That is another one of the things that I enjoy the most about this role. And I'm listing a few of my staff programs. Some of them come out of the hospital program. Some are things that we've developed here, as well as trusting relationships. As any chaplains on the call will know, if you do a great job caring for patients, then the people who referred you might trust you with their own needs. And I see that as a great honor. And then research has been an increasingly lively part of this role over time. Again, I'll speak a little bit, we'll come back around to these other projects, but just to say now that while we're building this position, right, you go from patient care with group focus, staff care builds, interprofessional care builds, and then these research projects come online as you generate more interest and momentum.
That's on me now. So talking about our initial approach to conducting research on this project, our first phase of looking at this was we really wanted to do a needs assessment of what our patients needed, what our staff needed and perceived their needs to be. And in order to do this, we created a we applied for and received a grant from Duke Ahead, which is the Interprofessional Education Academy at Duke that funds research that is, again, interprofessional, and they liked our project. I can't see the slides right now, by the way. And so
hold on, that's really bizarre. I'll be there. Is that better?
Yeah, right.
Okay.
So our phase one was assessing the knowledge of chaplain role and identity in an outpatient healthcare setting. So what we set out to do was a double-pronged survey where we surveyed through, an emailed survey link to our interdisciplinary staff team, our physicians as well. We had a paid research assistant who went to our waiting room and collected surveys from our patients and their family members who were waiting appointments there. And so that was our initial survey, which was done right at the beginning of this whole thing in 2019, before the world changed. And then phase two ended up being a second phase once things calmed down sufficiently with the pandemic and things, to do some further assessment of our patients' needs relating to chaplain. And so that ended up being a round of surveys in late 2021 and early 2022 that we conducted. So as I mentioned before, we received a $5,000 internal grant from Duke Ahead to basically our research plans in place to fund some iPads to take surveys, some time for a research assistant to conduct surveys, and basically pretty bare bones grant. But we, as I said, conducted this survey in our waiting room and through online email survey links. And we asked, we kind of designed the survey to, from my previous experience prior to this project, had done a little bit of work with chaplains, and I had a strong inkling that people, and just from conversation, I didn't necessarily have to do research to know this, people are not really aware of what a chaplain is or what a chaplain does or where they come from, and there may be misconceptions that that staff have, that physicians have, and so I wanted to know we created like a set of factual questions that could be answered like true, false, and then ask people, what do you think the answer to this is, or do you not know? And so we looked at the knowledge. We looked at attitudes toward chaplain involvement, some questions to our staff about, how important do you think this is for your patients to have this kind of care? What concerns do you have about it, et cetera? And then to better capture sort of what our patients' needs are, since we're not, necessarily just getting a pool of people who are facing, a particular clinical scenario, we created a bunch of hypothetical scenarios, initially a very large number, and then we winnowed it down, which we may talk about. So we started at 18, we culled it down to 7 or 8 things like, I'd like to have somebody to just listen to me. I would like to have somebody talk to me if I was facing a life-threatening illness. I would like to have somebody pray with me. I would like to have somebody to talk to about my mental health. Just a variety of things with a Likert scale answer of I definitely would, or I probably would, or I probably wouldn't. Anyway, and then we so one of the outputs of this survey is that the grief was a common popular desire from patients to have somebody talk to them if they were grieving a loss. And we were able to publish this short survey in the Journal of General Internal Medicine. It was fun because one of our resident physicians, who subsequently moved on to her, professional career, was our lead author on that, which was great to get her involved. Dr. Stavik, who's now in Montana. If any of you are in Montana, look her up. So we found that patients and providers may misunderstand the chaplain as a paid representative of a religious denomination. A lot of people, if you talk, if you just kind of probe them a little bit, will say, well, this person's probably like doing missionary work for some, some church. That's a little uncomfortable for me. We wanted to, one of the misconceptions we thought people had correctly is this particular one, and we wanted people to be more aware that these are master's level professionals certified and employed by healthcare institutions. And I know that there's some fuzziness there about, when clergy are called into a hospital to do chaplain things, and a lot of clergy do some chaplain training. So for people, it can be very confusing to know exactly what the level the person seeing them is. And another one, medical team may misperceive that chaplains are trained only to respond to religious patients or those from their own tradition. This was an important one. I've received so many questions about this. Like, even when you talk to people, like, okay, if I do a spiritual assessment and I find out that the person's a Sikh, like, I don't know what to do with that. And what does that information add to me, and can a chaplain even help in that situation? So we wanted people to know that chaplains are trained to support patients and families of all worldviews, faith, non-faith backgrounds. And so that's what we're kind of trying to get at with our true-false knowledge survey as well. Staff and patients are generally unaware that chaplains have a broad-based standardized training that they do. And one of the things that seems to actually be very salient with patients when we were looking at the survey, the patients who are correctly identified that chaplains are there actually for patients and for staff members, the people who correctly identified that were much more likely to want to talk to a chaplain, which is one thing we highlighted in the paper. So we thought, with all this information, that improved knowledge about chaplaincy services and like what goes into a chaplain's formation and professional identity could have multiple benefits for medical teams and our patients. So after we'd done that first assessment, principally looking at this knowledge question, we wanted to test sort of an experimental way of testing, well, if we kind of clarify some of these misconceptions, would that alter people's reported desire to see a chaplain? And so we call it quasi-experimental here because we couldn't go back and survey the same people. We took a convenience sample again in our waiting room of people, and this time we prepared an informational brochure with some nice pictures on it, and we gave it to the people and said, hey, would you like to take a survey? And then said, like, please read this brochure before you take the survey, so they could like really pass the test well. And it's really interesting because we, well, I'll tell you, our first question was, does improved awareness of this role in training increase the desire for a chaplain service? And the first thing that was really interesting is, one, this was like in sort of the fall and winter months, right sort of the Delta wave and the Omicron variant and things like hitting. And number one, we had a lower response rate. Lots of people said, no, thank you, I just don't really want to do that. But then also the people who did do it, many of them just didn't really want to take a brochure and read it. So we have to actually go back and like refine the protocol and like really help the research assistant to like actually say, no, you got to look at this thing before you take our survey, which was interesting. But what we found is that, yes, the informational brochure was able to slightly increase people's factual knowledge. We went from like an average of like 4.6 out of 10 questions, so like 5.6 out of 10 questions right. But if you look at the people who, the people who took the brochure, they didn't have any real increase in their desire to see a chaplain for anything. So that was like our experiment, which didn't seem to be as impactful as some of the other factors that we could measure, like women were more likely to want to see a chaplain. That was statistically significant. People who had previously met with a chaplain were more interested in seeing a chaplain. As we'll talk about in a minute, people's innate religiosity was more predictive. So the second question, and what I was leading to, is how does patient desire for chaplain services in outpatient primary clinic vary with extrinsic and intrinsic religiosity as measured by the Duke University Religion Index, or the Durrell? We'll talk a lot about that today. The Durrell we chose is as a brief, useful, well-validated tool. We thought that high religiosity would be highly associated with a strong desire for chaplain support in the majority of the scenarios that we presented, with also the counter hypothesis that people with low religiosity might not be so interested.
So as Dr. Hemming said, this second phase of inquiry revolved around exploring how the Durrell might inform us as we explore which patients might be more likely to desire a visit from a chaplain. So this second phase of the research ended up showing up as we wrote this article together in the Journal of Pastoral Care and Counseling, and it really does focus on the Durrell as the Durrell moves, as we can see what patients' intrinsic and extrinsic religiosity scores are, and compared those to the scenarios of care that they might request a chaplain. So that's what the larger study is on. And we're going to go to the next slide. And the key demographics that we found were that most of our patients were 55 years and older. Over 2/3 were women. Fewer than 1/2 of the patients had a college education. And what was interesting is, on most cases, our religious affiliation tracked directly with the Pew findings for North Carolina, the Pew study on religion and spirituality in the United States. So that was a really interesting finding. There was one or two that were slightly different, and we'll talk about that. But it was really interesting that we were able to combine both the Durrell and in this other survey and explore how these surveys ended up informing us in terms of what we believe was important important information for spiritual care in outpatient clinics. Real briefly, the Durrell is a 5-item assessment tool, and I don't know if Patrick and Katherine remember this, but early on, I had used the Durrell in some other research endeavors. And I like the study because it's broad and it's easy to answer, and it doesn't take a whole lot of effort for the respondents to answer it fully. So that's one reason I like it. The other is that it's really widely used. So that was helpful. We can compare our results to other results as well. But it basically has three major areas where we're looking at external public extrinsic religiosity. That's one subscale. And then private extrinsic religiosity. In other words, how much are you religious in your life? How much do you go to church, or how often do you go to church, is one area. And then the second area is how much time do you spend in private religious activities. So those are both the extrinsic religiosity scales. And then the third one is an intrinsic religiosity scale that has got 3 questions to that one. And that's the questions have to do with internally, how does my religion or my spiritual journey impact my life? So question 3 is, in my life, I experience the presence of the divine. And then the second one is, in my religious beliefs are what really lie behind my whole approach to life. And then the third question is, I try hard to carry my religion into other areas of life. So this is a way to really explore if people are engaging their religion and their religious journey in their everyday living. When we got the results for this, the results landed in the public extrinsic religiosity. There was a broad spectrum of answers, which is a very key point. We'll talk about that. Patrick will explain why that's so important later. But in publicly religiously observant folks, we found that a few times a month, once a week, or more than once a week, that this was the answer. And so 13, I think we landed with about 46% of the people were publicly religiously observant in this slide. In the next slide, the privately religious was a little bit higher than people reported being privately religious at about a 57% chance. So those were two of the scales that we looked at. And then this next slide talks about, and this is interesting here because there's not a whole lot of difference. There's a lot more people that are responding of having intrinsic religiosity as an important part of their life. So these are the ways we broke that down. And as we go into our findings, you'll understand why these are important findings. So the next slide is, where are we? Next slide there. We're gonna invite Patrick and Katherine to talk about this slide.
I'll just say briefly that this is our kind of favorite diagram. This is sort of our most clear presentation of results. And so we're going to spend just a minute on this. So if you're just looking at this figure, the blue line, we're drawing, okay, so around this diagram are 6 of the most, the scenarios of greatest interest to our patients, okay? So we asked them, again, just returning to the survey instrument, we asked them, hey, do you think, to what degree might you be interested in seeing a chaplain for a listening ear, or to pray with me, or to help with mental health concerns, etc. Okay, and we're asking those same people, and by the way, how religious are you using this Durrell, right? Okay, so the blue line, which shows you higher percentages for each one of these scenarios, right, which we would have expected. The blue line is the folks who scored as more extrinsically religious, okay? So these are the people that are more likely to go to church regularly and are more likely to pray or meditate, okay? So public and private extrinsic religiosity. We found that the combination of those two subscales was the most interesting and significant and clear picture for us when looking against the Durrell, all right? And then the orange line that kind of follows a similar pattern but hugs to lower percentages, all right? We're gonna break down some of these results some more, but looking as a whole, you can say, oh, okay, the blue line shows that more religious people generally had a higher percentage of interest in these different scenarios. Less religious people had a less interest, okay? But you can see places where it's more divergent, right? So like if you look at help with physical health decision, well, neither one of those percentages is very high, but there's a pretty big delta between the high religious blue people and the lower religious orange people, right? So like that's an interesting place where religiosity led to a bigger delta in interest. All right, so Patrick, what else would you want to say about this?
Yeah, so John and Katherine thought that this would warrant a little bit more discussion why we chose the extrinsic versus the intrinsic religiosity. So I just wanted to go back to the other 2 slides for a second. So if we look through and we see, basically, if you were to put a yardstick, go back 2, yardstick across these 3 or a level, you would see that it's pretty evenly distributed on this question throughout the thing. You could almost see like sort of a straight line going across all of them if you kind of average them out. And then look at the next one. This one is not so linear, but it's distributed. So you got a bunch of people on the left side and a bunch of people on the right. This could be, look at a political map or something. But anyway, and then you, so you've got a distribution of stores. And then we look at this next one, the intrinsic, and you can't put a level or yardstick on this one. It is very skewed to the right. And so for statistical testing purposes, it's just not a very useful description for our study. It doesn't mean that the question's bad, but it means that in our population, we didn't get a very big spread of different answers on this question. So if I were trying to look at like the odds of somebody going into the National Basketball Association, and I was looking at the odds of being tall causing that, and I had a sample of tall people, I wouldn't be able to test that association because I didn't have enough short people to really test it. And that's where we're at with our particular sample. So that's why we're talking about extrinsic religiosity, which is also interesting conceptually. But I think what's interesting to me in this thing is where the two kind of pull apart, like help with physical decision making. Like most people think they're going to the doctor, they're going to see the doctor, and they're not going to talk to a chaplain about their heart failure. But the people who are lower religiosity are much less likely to do that than the people with high religiosity, where they kind of point together very closely with grief. That looks like kind of the most, where they're both pointy and looking similar. So I think that's interesting.
Thanks, Patrick. All right, so moving forward, so now the rest of this discussion of results is going to be drawing from these numbers. All right, so you kind of keep this little image in your mind as we go through a couple of points that we want to highlight in these results. All right, so the first is the listening ear scenario. So for this question, for this scenario, 86.3% of our more extrinsically religious patients were interested in seeing a chaplain for a listening ear. 70.8% of our less extrinsically religious patients were also interested. Okay, so these are high numbers across our patient population. So just, basic takeaway is our patient population, over 70%, regardless of religiosity, are interested in seeing a chaplain for a listening ear. Okay, that's kind of first takeaway. But when we started to look at, all right, well, how did chaplains think about their work, and how does that relate to perhaps how patients think about chaplains' work and why they might want to see us? Well, we started to make some suggestions, like, for example, this listening ear seems like pretty congruent, like that a patient probably understands what we mean by listening ear, and we also understand what we mean by listening ear, and that this is just really foundational to pastoral theology and practice, including things like accompaniment theory, which is Wolfelt's work, and the idea of listening to people so well that you facilitate the coming to voice of their heart's concerns, and that's Shaniqua Walker-Barnes. So this one seems fairly straightforward. High results, we think we understand the results. All right, help when grieving, this is still pretty high results, right? So 81.2% of our more religious patients would want to see a chaplain for grief care. 66%, 2/3 of our less religious patients would still want to see a chaplain for grief care. Okay, so this again underscored and kind of emphasized and validated our initial gut feeling that the programmatic focus in this clinic could do well to include a lot of spiritual care for grief. All right, so just this a little bit on how we play this out. The grief care that I provide here and that I provide in concert with the social work team is really focused on empowerment and mutual support. Huge efforts to normalize grief, to encourage expression of lament, and to reframe the concepts of strong and brave to include the ideas of reaching out for help, articulating feelings, expressing feelings, etc. So this is just like a little bit of theory that is probably familiar to many of you, but this is a conceptual framework that I like a lot. This draws from the Deal Gross Index. One of our colleagues here at Duke, Mike Gross, helped author a really wonderful spiritual assessment tool that I use all the time. And so we think about our help when grieving care as supporting the transition from spiritual distress toward wellness. And these are several metrics. These are continuum of distress to wellness criteria that we think about, and we try to accompany patients and empower them to move from the left side to the right side of this diagram. All right, so that's the help when grieving scenario. And then help with physical decisions, physical health decisions, right? So we already covered this a little bit. These are our lowest numbers, and this makes good sense, right? So 27.4 of our less religious patients would seek chaplain care here. That makes sense. Still half of our more religious patients would, which is kind of interesting. But yeah, we see ourselves as people that can support difficult conversations, help people answer their own questions, but generally we're not the ones answering specific questions about physical medicine, right? So this is congruent. The low numbers here are congruent with chaplain self-understanding, and we think is a nice, clear boundary around our work. So just, kind of lightheartedly, this is what chaplains don't do, right? So it's kind of nice that we see in the numbers that this is our lowest responses. All right, and then pray with me, I think is kind of maybe some of our favorite findings. So we expected really high numbers from religious folks. Okay, so 87.1 of our highly religious, extrinsically religious patients would love to see a chaplain for prayer. Fantastic. But wait a minute, 62.3% of our less religious patients also want to see a chaplain for prayer. This was like, we really had to scratch our heads on this, and I would love to hear from this community, why you think that is true. But we think in general the idea of prayer is consistent with the chaplain's role in facilitating lament, right? Facilitating sort of the crying out of the heart and the spirit to something broader than the self. I think we're interested maybe that if this high interest from the sort of less overtly religious folks might reflect sort of patient-led spirituality, like maybe they feel like prayer is more accessible if it's in their own language, or if it's spirituality on their own terms versus formal religion, right? Like extrinsic religiosity generally is more measuring participation in an established religious tradition versus praying in your own prayer language or reflecting your own personal understanding of the divine. So perhaps there's a nice congruence here with less religious people still finding some meaning in private prayer. And finally, this is a quote that I just really love. At the Parliament of the World Religions that I got to go to a few years ago, I heard Chief Philip Scott say that prayer is unfettered heart speak. And I just think about that all the time. So, in what way is the desire for chaplains to pray with me an expressed desire to be with someone who is going to listen to the speech of your heart and be there with you on that channel when offering it to something larger than the self, right? So in what way is prayer a shortcut to authentic and meaningful connection and authentic and meaningful speech? So those are some of our ideas about that scenario. And
well, I think that's a great segue into the conclusion. Some of the conclusions we've drawn are that this unfettered heart speech that we elicit and support and engage folks on, the way we support them in grief and the way we walk with them as they suffer as chaplains, that is actually what many of our patients need and want. And this is one research project that shows that is indeed true. There are several others that we reference in the article that talk about how basically proof of concept is that patient outcomes and patient satisfaction numbers are higher when chaplains are part of the team. And that's true in outpatient clinics as well. And it's also true that people that another researcher found the very same thing we found, which is even people that professed not having a religion still wanted people to talk to them about their heart language and what's going on in their spiritual journey. So this is one of the things that's a proof of concept for me as I begin to write my request for funding from the hospital at large to get another position funded for our chaplain. So that's one of our outcomes.
So that's John talking to number one here. And then number two is, in my CPE education, I was very fortunate. So I've been training in departments under John my whole time, but at the VA here and then at Duke here. But in general, it's pretty unusual to have outpatient training opportunities for chaplains. And so it is a different kind of care. It's a very different flow. It's a really different world out here. And so we argue that given the success of this pilot project and given our strong results for patient interest in chaplain care in the outpatient settings, that, well, then the chaplain education should be able to facilitate a pipeline of future outpatient chaplains by increasing training opportunities and topics and skills in relevant field placements.
Unmuted. And so I would just echo too that you'll hear a lot of medical people talk about the slow and steady movement of medicine from within hospital walls to without hospital walls, and so I think this is really a part of that, and I think our work bolsters some evidence that healthcare providers can do more of an assessment, and I lost the slides again, assessment of spiritual needs of their patients, and be more aware of the referral opportunities that present themselves as our systems change and adapt to a new reality. So we are here telling you all about what we've done so far. We are pleased to have been able to do all of this, and also anticipating doing more. And so we've got our thinking caps on right now and thinking about if we do a next study, what is the outcome we want to see? We'd like to look at things prospectively. All of this is looking sort of backwards. What would be the purpose and goal of something prospective that we set out to do now? Would be interested in some sort of measure of effectiveness, clinical effectiveness of what the chaplain does? Are we interested in satisfaction? Are we looking qualitatively at things that are hard to measure? And then also how do we get the funds and the resources to do something that's robust enough to really do justice to this really important topic. John, as the director of chaplaincy and education, is interested in how this what we've done out in our neck of the woods impacts his other clinics that he is staffing chaplaincy services for throughout our health system. We're interested in other institutions. I know Catherine's done a great job networking with you all and others who are doing chaplaincy research around the country, but also internationally. And so we are open to discussion and ideas here.
And we're about to conclude, but just finally, just to say that in the way that we grew the position, in small steps, in phases over the last 4 years, this has also been expanding to new kinds of clinical instruction. So sometimes I get to do joint visits with learners. Our social work interns help me run the grief support group. And then some of our physicians have actually originated their own research projects that relate to chaplaincy and advanced care planning in a resident teaching clinic, and then a narrative medicine project called Untold Stories, which is combining patient qualitative interviews with photography by one of our doctors, as well as efforts to do grief care in the community. I've been invited to do memorial services for some of our unhoused patients, led grief support groups in the community as well. And then we've also expanded recently to do chaplain care for another high need outpatient setting, which is our movement disorders clinic.
And people across our system are seeing the value that Katherine and her team of chaplains are bringing to our outpatient chaplain locations, and they're asking for more and more support. So that's both exciting and a little nerve-wracking because we don't have the people yet, and we're working on figuring it out. One way that I'm doing it is I'm seeing it as a chance for our CPE program to place interns there first, and then imagine perhaps a residency that's connected to that. Our Medicare pass-through dollars don't always support some of that, but nonetheless, that's where medicine is heading. So we're going to try to figure out how to keep training our students in that direction. The last thing that I really think we need to highlight is this advanced care planning. One of the things that in my vision of what we're doing is chaplains, we have a lot of things we want and care about doing, but we really need to focus also on the needs of the system. And our system really needs us to get a handle on advanced care planning. And if we can be leaders in that world, if not necessarily telling people how to do it exactly, but what Katherine has begun to do is to have clinics where she invites patients to have these conversations with her first, and then they can move them to the doctor to finish out the care, or provider to finish out the conversations. And those are actually billable visits. So these are just different ways that we want to do well by doing good, if that makes any sense. But I'm grateful for the time, and I know we have a few questions.
Thank you all. This was a very enlightening and engaging presentation, and the questions are flowing in. We're going to get to as many of them as we can. We know it's all about the money sometimes, right? So there's a lot of questions about money in terms of how do you fund this? Are you using ICD codes around advanced care planning? Is there billing for outpatient spiritual care services? You mentioned several grants. Can you tell us a little bit more about the finances?
Katherine, you want me to start there and you finish up? And
Yeah.
So the way we started it, we began it as the chaplain service feels like this is an important thing for us to do. And we had an intern that was interested in doing this with connections that made it all work. And so we began this very small. And that, I think, is a key thing, is to always begin something small, get the proof of concept, make sure they know and appreciate what you're doing. And that typically that money will flow afterwards as you become it. So we began it small. We had the Duke Ahead grant that helped us with the research. And then we had another grant from general internal medicine, that paid for the beginning of a residency. We kind of moved it to a residency salary as the next stage we did it. So it wasn't a full-on chaplain position just yet. But that first grant was from the internal medicine doctors at the clinic. So chances are that in most of your clinics, you have people that would love to see what you're doing expanded, and to try to find out if there are ways to get a grant through that funding. And then the next step was
I can also
yeah, go ahead.
I'll just add that was philanthropic money that Kate had come in as well. And so, the institutions have philanthropy. Hospital institutions often have grateful patients, and that's basically what this was.
So yeah, it's finding those dollars and making a case for them by doing the good work of the grief groups, by doing the good work of training the interns, and by doing those things. The last couple of quick things are, I don't know, Katherine, if you've been able to use the ICD-10 or 9 codes yet on the ACP yet, but that is a funding stream that we haven't yet figured out how to get to. But I do believe it's worth looking into, because any provider can get paid for that, and we would fall into the providers for that. The last grant we got was a larger grant that moved to a 3-year grant, and that's through the compassionate care program that chaplaincy actually has access to some grant monies that we were able to fund that among a couple other projects. So those are some of the ways we're paying for it. I don't know if there's anything else anybody wants to add.
Thank you. I also know there is some other research going on around ICD codes and advanced care planning. So want to direct you to that other research going on as another resource. We have a few nitty-gritty questions in terms of practice. So Katherine, these might be best directed towards you. How do you chart in the EMR for outpatient care?
Yeah, I chart, all my charting is narrative. And this is actually a really lovely part of the interdisciplinary work. So I typically, I chart using the Deal Gross spiritual assessment. I put the most salient spiritual distress to wholeness sort of symptoms, basically. And I do narrative work with as much quotes, direct quotes as possible. I always put at the top who referred me. I always put at the top a plan for closing and follow-up. And then I will actually sign the chart note, and I will always forward it to the referring person and any other professionals that are indicated for follow-up, as well as often the primary care physician. And then that's just kind of a way that I'm in constant conversation with my colleagues. And they don't have to read it all, but they can at least say, oh, okay, well, the chaplain did make it in to see that person, and if I have questions, I can follow up.
And can outpatient and inpatient providers, chaplains see that note?
Yeah, it's in the medical record, and it's visible to patients. It's visible to everybody. It's yeah, fully available.
Perfect. A few more practice questions, and then we have some study questions. How much of your time is spent as a chaplain on doing advanced care planning versus spiritual or emotional support?
Right. I mean, I think advanced care planning work, if done well, is also emotional and spiritual support. But in the current format, I'm doing like maybe 15% of my time, maybe 20 on certain weeks, but like no more than 15% of my time right now is allocated towards this structural work of kind of, we basically have a high risk for hospitalization list of patients. And I go through that list and I say, oop, these 10 people do not have any advanced care planning on file. We are their primary care physician and they're at high risk for hospitalization. And I do outreach specifically to the patients and to the primary care physicians to try to move that forward. So that's my primary ACP mechanism right now.
Okay. And then finally, does it matter if the grief of the patient or family is unrelated to the present health issue? And is there an avenue for referral if grief concerns go beyond the chaplain purview?
So yes, I mean, I do bereavement work regardless of when, you know, if the bereavement is still weighing on the person to the point of interrupting any kind of function in the present, or just indicating spiritual distress, indicating emotional distress, that's more than enough for me to do my work. And it often can show up physically. And regularly patients will tell me, like, I'll be referred for bereavement care, often after a traumatic incident. For example, we do a lot of care in the wake of violence here. And I'll be talking with a patient and they'll tell me all about their grief. And then they'll say, and you know, when this all started, I had so much stomach pain and I just lost 20 pounds. And so then I chart that and I immediately route it to the provider. You know, I encourage the patient to call and make an appointment. I route it to the provider. I let anybody know who might want to know about that, you know, and I just kind of keep raising the flag. If I'm given any medical information, I just keep routing it out to providers. But I think it's almost impossible to distinguish whether or not a grief from 10 years ago is causing current pain. We could never know that. So the question for me is it significant enough to be impairing the person's function in some way or their well-being?
I love that answer. And I think of wholeness is where we're going. And so it could be, you know, we're working for the patient and their journey, not just one particular event in time. So that would, yeah.
Here's a few questions about the study in particular. Was the term spiritual care provider used at any time, or was it always chaplain? And can you explain the reasoning behind that?
We didn't use spiritual care provider. I'll let the others say if they had any consideration of that. I mean, I think, well, just before, like, we were a spiritual care provider, obviously has, I'm not as familiar with that term in a clinical setting. So for me, that would mean like also, you know, the pastor in my particular denomination or something like that, which is not what we were seeking to ask about. But again, I'm not as familiar with the term.
That probably gets at, there's a lot of baggage around the word chaplain, and so that's a hot button issue we come up against frequently. But in terms of getting at conceptions of a chaplain, it sounds like using that term for you guys was pretty pertinent.
It seems to work in our milieu. That's all I can say. Yeah.
Okay. So, hold on, I just lost my train of thought. Did the survey that you use include written definitions of grief and spirituality?
We did. If you look at, are we sharing the? If you look at the article, or if we have shared any information about it, we have a link to the actual survey itself. So if you want to review it, apply it to things you're using. And so we do have a definition of spirituality in there that we used to frame the survey questions. Sorry, what was the other?
I'm putting that link in the chat right now.
Yeah.
And I know there was also a request to the spiritual assessment you used, and that's the Durrell, which I think is publicly available, right?
Yep.
Okay. And then there was one comment on great research project. We definitely want to highlight that. Can you conceive of a parallel study in a less religious state? If so, any states you'd be interested in?
Katherine, you looked at some good studies published in New England and other parts of the country.
Yeah, I think it'd be fantastic to do this in other places. I mean, you don't need to have high data. You're doing it as a needs assessment, right? So, so the point is to really understand the people that you're serving, and I think you could get lower percentages and still have really interesting data. I think you could also, design in a less overtly religious place. You could also design questions around. Okay, well, if you're less religious but you'd still want to see a chaplain, like why? Or, I think you could go deeper into the spiritual but not religious in a different setting.
And there's a lot of really great related work in Europe too. Like I see stuff coming out of like Switzerland and Netherlands and United Kingdom and stuff. So.
Absolutely. One more practice question. I do want to highlight that this is some of the great work happening in chaplaincy research. If you're interested in getting involved in yourself, we do have an outpatient chaplaincy care research network, and I've included my email if you're interested in that in the chat. One more practice question and then one more overall question. I know we're butting up against the hour here. So Katherine, do you schedule appointments with the patients or do you see them when they're already in clinic?
Yeah, I do both. And that's a really interesting and tricky balance. I try to be as available as possible. If someone comes, if I'm in the middle of something that I can put down and someone comes to me with a real-time referral, I do everything I can to put it down and go. But about a third to a half of my time is scheduled visits. I schedule my own time. It does not go into the medical record. I schedule my own time in the same way as our social workers do. So my calendar looks a bit more like a clinical social workers would, with a combination of kind of just free clinic available times and scheduled visits. And then I do my own reminders, et cetera. So I won't typically do more than like 5 visits with someone. I try to target 1 to 3 visits if someone wants kind of in-depth spiritual care. And I bound it like that.
Thank you. And then finally, one of your most interesting findings from your study was, people don't want to talk about the physical needs with a chaplain. And yet we're getting involved in advanced care planning, which can involve some of those physical discussions. Where do you see the line there, and how might the chaplain operate in the interprofessional team in that way?
I mean, I think each of us could answer that in a different way. I'll just say briefly that some of the most interesting advanced care planning referrals that come to me are patients who say they don't want to do advanced care planning because God's just going to take care of it, you know? And so kind of being a spiritual professional who can hold that with great respect and try to get one level deeper, like, well, what does it mean for God to have that for you? You know, how can we as your team be respectful in the midst of God having that for you, right? And sometimes there's more detail there. Sometimes that's just a way to say, I don't want to talk about death. And we're not going to push people to talk about death, right? But it's this where we come into sort of religious barriers to having these conversations, I think is the most obvious place for a chaplain.
Any alternate views of our co-presenters, or just a yes, we agree?
Slightly different in that, again, advanced care planning is always about finding out what their heart wants and needs. And I don't know that it's so much about the physical realities that they're facing, other than but the emotional and spiritual challenges they're facing as a result of their physical challenges. So those are that feels like the question we were asking is, do you want us to talk to you about your physical care? And they more want to talk about what's happening because of their physical experience, is my experience on that. And just a line that I use with our students all the time is, all chaplaincy is palliative care. So we're looking at the symptoms and providing symptom relief and engaging in those things, and having the conversation about their advanced care is often a way to get to what's really causing them the most pain. So I've experienced my team members appreciating chaplains and spiritual care providers being available to have these deep conversations with folks.
I'll just add my thought on that, which is that we actually did ask some ethicist colleagues about that question, and they raised some interesting ethical questions, particularly around sort of the morality that is inherent in kind of a spiritual care provider's role, and then these potentially high stakes decisions. But what I thought was really useful in the study was that the people that we surveyed who had previously met with a chaplain and reported it to us in the survey, they were like 64% of them wanted to talk about their physical health with a chaplain. You know, and so really advanced care planning is intended to be something that's relational, and if somebody has either a personal relationship with the other person having a conversation with them, or I guess a relationship with the professional nature of that person, then it becomes a bit more okay for the people to do that. They're more open to that. And whether that person be a chaplain or a social worker or a physician, if that person has a trust and a good relationship, then that's a valid conversation to have, and very helpful for everybody else who's trying to help.
Thank you. Great perspectives. Well, Dr. Oliver, Dr. Hemming, Reverend Henderson, thank you so much for presenting. I know in our chat I didn't get to all of the questions. Those that are more about the nitty-gritty of the article, you have access to the article, the definitions they use, the terms they use, all that's in there. It's a great read. I think the figures you presented to us today are only the beginning, and so excited about the work that you guys will do going forward. Thank you for your time. And if any are interested in getting involved further, either in asking questions of this team or working across institutions, I've included my email. Happy to connect you. Also happy to connect you to the research networks. In the meantime, I hope you guys have a great afternoon. We'll see you another time.
Thanks, everybody.